So I'm Karol Watson. I am a cardiologist at UCLA. I run the Women's Cardiovascular Center, and I co-direct preventive cardiologist. And as my husband calls me, he thinks it's a dig. I'm actually really, really proud. A lipid nerd and a hypertension nerd. So I'm going to talk to you about how I manage elevated triglycerides. Now, triglycerides are like the stepchild of lipidology. LDL is where all the action is. We get that. It is the most important lipid fraction. But I think of triglycerides as uniquely important. I think of it as where the fat meets the fire, because triglycerides are really pro-inflammatory. They really are. And it's not just the triglycerides themselves, it's the company they keep. They always go with insulin resistance and probably prediabetes or diabetes, but I think of it as inflammation plus atherogenic lipoproteins. So I think triglycerides are uniquely important. These are my disclosures. None of these will impact the presentation today. So a bunch of different lipoproteins. And we focus on LDL, and that's important because it is the most abundant cholesterol-containing lipoprotein in our bloodstream. But what we do every day and eat every day, that bacon and eggs we just had, it shows up in our bloodstream as triglycerides. The big, big, big triglyceride-containing particles that are secreted through your gut, chylomicrons, that's what we just ate. And then the triglyceride-containing lipoproteins that are secreted by the liver, the VLDLs. Hypertriglyceridemia is really important. This is actually older data, and it's even more important now because, as I'll show you in the next couple of slides, the predisposing factors to hypertriglyceridemia are becoming more and more and more prevalent. But this is overall looking at some of the data. If you use a cut point of greater than 150, about a third of people overall will have it, about 15-16% of people if you use a cut point of over 200. I would tell you, neither of these cut points is truly normal. Truly, truly normal fasting triglycerides are like around 100. So even when you get up to the 150, we're starting to look at some triglyceride abnormalities. And you can see certain groups, there's differences, and certain ethnicities, like Mexican Americans, have higher rates. And every time we look observationally, we see that hypertriglyceridemia increases CHD risk. It's not as direct relationship as LDL, but there's absolutely a relationship. So as I've said, many of the causes of elevated triglycerides are lifestyle, and they're increasing in prevalence. Overweight and obesity, physical inactivity, excess alcohol intake, high carbohydrate diets, some drugs, and some genetic abnormalities. Like remember in medical school, you heard about all those genetic causes of hypertriglyceridemia, and we understood that fat reduction was the important thing to do. Well, now in today's society, those are a rare cause of hypertriglyceridemia. Most of the causes are related to insulin sensitivity, insulin resistance, and somewhere along that pathway. So high carbohydrate diets, high glycemic index foods, overweight, obesity, diabetes, prediabetes. Because of that, most of the treatments actually that we can do are lifestyle related. But when that doesn't work, we have to think about drugs. And what are the drugs we think about? Well, niacin, nicotinic acid containing compounds, fibrates. These all have a significant reduction in triglycerides in the laboratory or clinically when you see a patient. But the question is not just lowering the number. The crux of it is lowering risk. And so what we have had to learn for many, many studies is that changing the number doesn't always change the risk. How many times have we raised HDL? Enormously, and thought, oh my gosh, we're going to lower risk so much. No reduction in risk, and some increase in some studies. In both niacin-containing and fibrate-containing compounds, we've lowered the numbers, but we haven't lowered the risk. The one group of compounds that did lower risk are EPA-only containing fish oils. But let's talk about the niacin trials. Well, AIM High and Heart Protection Study 2 were the two trials that mostly put the nail in the coffin of niacin. Both of those used individuals with high triglycerides and high cardiovascular risk to see if treating them with statin alone or statin plus niacin reduced the risk. And in both cases, nothing. Those curves are superimposable. And when you looked at, I was on the DSMB for AIM High, there was a slowly increasing, statistically significant increased risk in thrombotic ischemic strokes in the niacin-containing group. And in heart protection study, there was an excess of adverse events in the niacin-containing group. So not only no benefit, but a lot of side effects, some potentially very serious. Fibrate trials. We had many, many years of fibrate trials, and VA hit, some showed benefit and it looked pretty good. But if you go back and look, every single trial that showed any benefit of fibrate therapy was either in the absence of statin therapy or severe subutilization of statin therapy. In the statin era, with well-controlled LDL, fibrates have shown no benefit at all. The most recent example is from the Prominent trial. It's a novel fibrate. I presented this as the discussant as a late-breaking clinical trial at the AHA. Again, all the reason in the world to think benefit. They chose the right group, high triglyceride, low HDL, high cardiovascular risk. All of them were on a statin, and they saw nothing. So, again, fibrates are not showing benefit, and there's some signals that they're showing harm. This is from the ACCORD trial. The ACCORD trial was a study of newly diagnosed type 2 diabetes patients to see if blood pressure control, glucose control, lipid control impacted outcomes. In the lipid subgroup, they looked at everybody getting a statin and half getting a fibrate on top of that. They saw no benefit in the overall cohort, and if you looked at the subgroup of women, there was actually a statistically significant increase in risk. So again, fibrates are not just neutral. It shows in some settings they may be harmful. But what we've seen is with EPA-only fish oils, there's some benefit. This is data from the Reduce It trial, cardiovascular risk reduction with icosapent ethyl for hypertriglyceridemia. And so this was a good study, and they designed it very cleverly. So they had two cohorts, a secondary prevention cohort and a primary prevention cohort. They had to be, have either established cardiovascular disease, that was the secondary prevention cohort, or really high cardiovascular risk, the primary prevention cohort had to have diabetes and at least one other risk factor. They had to have triglycerides over 150 but below 500, and LDL had to be well controlled on a statin. Again, these were the inclusion criteria for the primary prevention and secondary prevention cohorts, so they chose the right group of patients to study. And this is what you saw. In those, so everyone got a statin and half got icosapent ethyl only containing EPA, and what they saw was a significant risk reduction in the primary outcome, which is a composite of cardiovascular death, MI, stroke, revascularization, and unstable angina. A 25% relative risk reduction, a 5.3% absolute risk reduction, which makes the number needed to treat very small, only 21. And then the key secondary endpoint, the big three, cardiovascular death, MI, stroke, a equally as impressive risk reduction, number needed to treat of 28. Looked really good. Now, what is the downside? If you look in all the important second subgroups, they showed benefit. So whether it was the secondary prevention cohort or primary prevention cohort, there was benefit. Whether they were male or female, there was benefit. If you were looking at U.S. versus non-U.S. benefit, and if you're looking at patients with diabetes versus no diabetes benefit, and finally, if you're looking at really high triglycerides or less high benefit. Last one. This is the triglyceride one. Now, what were the downsides? Well, there were some side effects. So one of the things that was shocking and surprising to everyone, there was a statistically significant increase in atrial fibrillation in the fish oil only group. That is something that was on nobody's radar screen. They thought there might be some antiplatelet effects and maybe some bleeding and things like that. No. But what they did see was a statistically significant increase in diagnosed atrial fibrillation or atrial flutter, p-value of 0.004. Still trying to figure that out and trying to figure out what it means, but that was seen. And there was some controversy. So it was everyone on a statin, half randomized to icosapent, only EPA-containing fish oils, or the comparator, which was mineral oil. Think about a placebo. There's like two really important things that a placebo is supposed to do. It's supposed to be invisible and inert. Nobody's supposed to know they're on a placebo or not. And secondly, it's not supposed to impact outcomes. So one of the things was people kind of knew they were on mineral oil, because what does mineral oil do? We use it to help people poop, right? So people kind of knew they were on mineral oil. The other thing was it was not inert. It raised LDL. It raised C-reactive protein. It raised ApoB. And when you look at those changes, they were not insignificant. But when the FDA looked at all the data and looked at the outcomes, they said, given the magnitude of benefit seen, we think there's still some benefit. So it probably over-predicted what the true benefit is, but we still think there's benefit, and we're still going to approve this for this indication. Now, why EPA only? So for years, we've just said fish oils, fish oils, fish oils. Well, think about it. There's three major components of fish oils, 2 long chain and 1 short chain. The short chain one is ALA, which is present in a lot of non-marine sources like nuts, walnuts, etc. The 2 long chain are EPA and DHA. And we said, they're all the same. Just treat them the same. But when we look at them, there's differences. Differences in cardiovascular risk and differences in biologic effect. So this is looking at the slide of effect of EPA, and you can see the nice reduction in cardiovascular risk in the line above. DHA, kind of nothing. What we know about the biologic effect is that all fish oils reduce triglycerides, but DHA has a unique increase in LDL. EPA-only fish oils really do not. And there's differential effects on the membrane wall. So when you think about all lipids, all fats that we eat, the lipids intercalate themselves in our membranes. If you're EPA, they do a really nice job of straightly intercalating into the membrane, so they appear to be membrane stabilizing. DHA is kind of a curly Q. It's a cute little molecule, but it can be a little bit membrane disrupting. So it's not likely as stabilizing as EPA. So where do we go? Right now we have EPA only containing fish oils as the main evidence-based therapies to reduce triglycerides. But in the future, we're going to have more. There's so many different proteins that are involved in lipolysis of triglycerides. ApoC3, which decreases it, ApoC2, which increases it, angiopoietin like protein 3, a lot of different things. And there's clinical trials in development for all of these right now. So we're going to have more therapies in the future, and we'll see if they impact outcomes. This is data on targeting angiopoietin like 3 protein for triglyceride lowering. It's using siRNA called vupanorsen, something like that. So it's an antisense oligonucleotide. It attacks the hepatic production of angiopoietin like 3 protein mRNA. So you make the genes there, you want to make the protein, but you're attacking the mRNA, the template for the protein, so you don't. And you can see there's really nice reductions in triglycerides with just therapy. No idea if it's going to reduce cardiovascular risk, but we'll see that in the future. Okay, so how do I manage elevated triglycerides? Never forget your statin. Statin, statin, statin. That is the basics for cardiovascular risk reduction. Then I make sure I try to institute lifestyle interventions for everyone. And then in patients who need more, I use icosapent ethyl containing fish oils. Thank you very much.